Esophageal disorders. In this video, what are the contents we are covering? I will give little brief explanation about esophagus, where it is located, how many layers it have, and little physiological function. Then after we are studying here pathological disorders. What are the disorders we are covering? First one, tracheoesophageal fistula, esophageal web, Juncker diverticulum, Mallory-Weiss syndrome, esophageal varices, and achalasia. If you see this picture, in this picture you are seeing one tube-like structure. This tube we call esophagus. Esophagus is a fibromuscular tube. If you see that length of that esophagus, it will be 25 centimeters. It originates from the inferior border of the cricoid cartilage. It will be in C6 level and it extends to the cardiac orifice of the stomach. It's in a T11 level. If you see the main function of esophagus, that esophagus will help for passing food from pharynx to stomach. In gastrointestinal system, only esophagus is the narrowest region of the alimentary tract, except vermiform appendix. If you see this image, in this image, in 15 centimeters, you will get upper esophageal sphincter in this area. This is upper esophageal sphincter because if you see this image, in this 15 centimeters area, you will get upper esophageal sphincter. The esophagus have two types of sphincters. One is upper esophageal sphincter and lower esophageal sphincter. In this 15 centimeters, you will get upper esophageal sphincter. This upper esophageal sphincter is voluntary condition and it's made by striated muscles. It's present at cricopharyngeus area. Then after, in 25 centimeters, you will get arch of aorta. Then after, in 27 centimeters, you will get left main bronchus. In 40 centimeters, at T11 level, you will get diaphragm. In the diaphragm, we call cardiac orifice. In that area, you will get lower esophageal sphincter. This lower esophageal sphincter will be in physiological condition. It is involuntary condition. Right? If you see this image, you can appreciate this image. This area we call pharynx. In this pharynx is divided into three parts. First one, nasopharynx, oropharynx, and laryngopharynx. If you see here, this area is called posterior to the nose. You call this is the nasopharynx. If you come down after soft palate, if you see this place posterior to the mouth, we call this is oropharynx. If you come to the down to the epiglottis, if you see here posterior to the larynx, you will get laryngopharynx. This nasopharynx and oropharynx between, if one palate is there, we call this is soft palate, and we also call this is uvula. Then after oropharynx to laryngopharynx, in between one body is there, that body we call epiglottis. Now esophagus, how that blood produced, arterial supply we are seeing here. The esophagus will get blood from branch of aorta and inferior thyroid artery will provide blood to the esophagus. For drainage, inferior thyroid of veins and azygos veins will drainage the blood from esophagus. If you see the innervation, in innervation for the parasympathetic, you will see vagal trunk. In sympathetic nervous system, you will see cervical and thoracic nerves. Now, histology of esophagus. If I cut esophagus, I can observe four types of layers present in esophagus. This is mucosa, submucosa, muscular propria, and adventitia. In mucosa, it's made by non-keratinized stratified squamous epithelium. If you see the submucosal layer, you will get some blood vessels, lymphatic vessels, little glands, and plexus will be there. In muscular layer, you will get two types of layers. One is circular layer and longitudinal layer. This circular layer will help for narrowing the esophagus. If you see the longitudinal muscle, it will like compulse and stretch will be done. If this both will work together, we call it is a rhythmic contraction. That rhythmic contraction we call peristalsis. In this esophagus, as I told you before, it's divided into three parts. First one, superior third, it's made by voluntary muscles, voluntary striated muscles. Middle third is formed by voluntary and smooth muscle. Inferior third part will formed by smooth muscles. Innervation of this esophagus layers, that submucosal layer and circular layer, in between one plexus is there, that plexus we call submucosal plexus or Meissner plexus. Circular and longitudinal layers, in between one plexus is there, that plexus we call myenteric or Auber plexus. Now we are saying swallowing process. If we see this guy, this handsome guy, he eating some pizza. He chewed that pizza slice and it's mixed with saliva and it formed like bolus. Then after that bolus coming to down part. If you see this second image, that bolus coming to the oropharyngeal space. In that space, one soft palate is there. That uvula will be elevate upward. Why? If that uvula is not elevate, what will happen? That food will goes to the nasopharynx area. That's why that uvula will elevate. In third picture, that food passing to the oropharynx to laryngopharynx. If you see this laryngopharynx, you will get one body. This body we call epiglottis. This epiglottis will covers the trachea area. Why? If that epiglottis is not covered, what will happen? That food will enters to the trachea. If in trachea, like water or food materials, if enters into the trachea, means we will get aspiration pathological condition. This aspiration means some material accumulated in trachea. So this epiglottis will cover the trachea area. Then after what will happen? Here, as I told you before, in C6 level, you will get upper esophageal sphincter. When food passing, that time, upper esophageal sphincter will be relaxes. Because of that relaxation, that food passing to the esophagus. In that esophagus, peristalsis movement will be there. Because of that peristalsis movement, that food will went to the stomach. This is the process of the esophagus. Now we are going to see the pathological conditions. First one, tracheoesophageal fistula. This is the congenital defect. Malformation of trachea and esophagus. Congenital defect resulting in a connection between the esophagus and trachea. Here, if you see this picture, this is the normal anatomy of trachea and esophagus. In tracheoesophageal fistula, what will happen? Some esophageal atresia will forms. Because of esophageal atresia means we call it will be like narrowing. Because of narrowing, if we giving any food to the baby, that baby will automatically vomit. So in this first part, you are seeing pure esophageal atresia. In second point, you are seeing here pure tracheoesophageal fistula. This will be in HC. In this defect, what will happen? After food passing to the esophagus, that food will enter to the trachea. Because of this malformation, you will get aspiration problem. Next, this is the most common. If you go to hospital, you will get this type of 85% of this type of disease you will get. This esophageal atresia with distal tracheoesophageal fistula. In this disorder, what will happen? This esophagus part didn't attach with trachea. So that's why that food will comes here and automatically that baby will vomit. What are the signs and symptoms you will see in this disorder? Vomiting, polyhydramnios, and abdominal distension and aspiration you will see in this tracheoesophageal fistula. Next, esophageal web. In esophageal web, what will happen? One mucosal layer will form in that esophagus area. If you see this picture, you can appreciate here one mucosal layer forms. This mucosal layer we call thin protrusions of mucosa. This is idiopathic, unknown cause. It will forms. It is mainly you will see in women older than age 40 years old. In this disorder, you will observe dysphagia and poorly chewed food. If any person is eating food with poorly chewed, then what will happen? In this area, that food will be stuck. Because of that food is not going to down. That's why that patient feels difficult in swallowing. In this esophageal web, you can observe after it will develop squamous cell carcinoma. What are the clinical features we will see in esophageal web? Patterson-Brown-Kelly. It's also known as Plum-Wilson syndrome. This Plum-Wilson syndrome, you will get dysphagia, iron deficiency of anemia, esophageal web, beefy red tongue because of iron deficiency, and atrophic glossitis. Glossitis means inflammation of tongue. Then after chiliosis. If you see this picture, this is the chylosis, because in lips surroundings some rupture will forms and it will like painful sensation will be there. This is the beefy red tongue, right? For esophageal web, what are the treatment is there? In treatment, they will give endoscopy dilation. Next, Juncker diverticulum. If you see Juncker diverticulum means out pouch is forms. That out pouch we will call false diverticulum. Actually, diverticulum is divided into two parts: true diverticulum and false diverticulum. In true diverticulum, you will get 4 layers like mucosa, submucosa, muscular layer, and adventitia. In false diverticulum, you will get only mucosa and submucosal layer. In Juncker diverticulum, you will get in pharyngeoesophageal muscle, you will get false diverticulum. This Juncker diverticulum most commonly affected by elderly males. If you see this picture, here you can observe thyropharyngeus muscle will be there and cricopharyngeus muscle will be there. In superior part, thyropharyngeus will be in oblique muscle layer, and in cricopharyngeus muscle you will get transverse layer. In middle you will get one Killian triangle. This Killian triangle will be like thin. Because of that problem, what will happen? One pouch will forms. That pouch we call Juncker diverticulum, right? Because of this this pouch, it presses that esophagus part. Because of what will happen, dysphagia will happen, and obstruction and gurgling, aspiration, and foul breath will occur in Juncker diverticulum. Foul breath is also called bad breath or halitosis, and many names are there. Next, neck mass also we can see in this Juncker diverticulum. We will give barium to swallow. After we will take imaging, you will get this type of picture. In this picture, you will see here, this is the diverticulum. For the treatment, we will do removal of diverticulum. After this diverticulum, they remove that pouch and they will close with strictures. This is the Junker diverticulum. Next we are going to see Mallory-Weiss syndrome. In Mallory-Weiss syndrome, longitudinal laceration will forms in distal part of esophagus. Where it is located? At gastroesophageal junction it's located. In this part you will get tears will be have in this part. This is we call Mallory-Weiss syndrome. In this Mallory-Weiss syndrome you will have like severe vomiting and more amount of alcoholism and bulimia, more amount of eating. These people have this type of disorder. It is very painful and hematemesis. Hematemesis means vomiting with blood. Next, this is the risk of Bauer-Have syndrome. If you see this image, you will get esophagus and stomach attached. Here, because of this type of laceration, what will happen? One rupture will be there. Because of that rupture, one hole will forms from that hole. That air will going to the mediastinum part. That's why if you see in imaging, you will get this type of picture. Here in mediastinum area, you will get air, right? This is the Mallory-Weiss syndrome. Next we are going to see the esophageal varices. In esophageal varices, in distal part, that blood vessels will be dilated. Where it is present in submucosal, blood vessels will be dilated. If you see this picture, this type of dilation of blood vessels will be happen. Normally, this esophageal blood will drainage into the portal vein. But here what will happen, because of portal hypertension, that blood will goes backward to the esophageal part. That's why this esophagus blood vessels will be dilated. In this esophagus varices, you will get painful hematemesis because after dilation, that blood vessels will be ruptured and that blood will goes to the stomach area. In that time, because of that irritation, you will get vomiting. In that vomiting, you will have that blood. That's why we call this is painful hematemesis. Most common death in cirrhosis. If patient have a liver cirrhosis, means that patient will get this esophageal varices. Next we are going to see the achalasia. If you see this achalasia, this is a disordered esophageal motility with inability to relax the lower esophageal sphincter. In achalasia, what will happen? That distal esophageal sphincter will be constricts, it incompletely relaxes. Why this achalasia will happen? Two types of problems will be there. Because of mesenteric plexus, damage of ganglion, this is the idiopathic, we will call this is primary cause. And secondary cause, it will damage mesenteric plexus because of Trypanosoma cruzi infection. We will study in Chagas disease. In achalasia, we will get one triad. In triad, what will happen? First one, incomplete of lower esophageal relaxation will be occur. Then after increase, lower esophageal sphincter tone will be formed. Then after aperistalsis, that peristalsis is absent. Next, clinical features: dysphagia, difficult in swallowing, difficult in belching, and chest pain. Same to some like this in achalasia patient, they will feel like some heart attack type feeling they will get. And high lower esophageal sphincter pressure on esophageal manometry. If you see the imaging of achalasia, you will get broad beak type of structure. And because of this achalasia, it causes risk of esophageal cancer or small cell carcinoma. If you see here this image, here achalasia of esophagus will be there. In this distal part of esophagus, what will happen? That esophagus are narrowed. Because of this problem, that food is not going to the stomach. If you see the imaging, you will get this type of picture, bird beaks picture, birds beaks structure. And what are the treatment? We will give calcium channel blockers and nitrates for dilation. First one, GERD. GERD means gastroesophageal reflux disease, Barrett esophagus, eosinophilic esophagitis, distal esophageal spasm, and esophageal cancers. First one, gastroesophageal reflux disorder. In this disorder, lower esophageal sphincter will relaxes. It decreases the tone. Why? It reflux of acid from the stomach due to reduced lower esophageal sphincter tone. If you see this picture, in this picture, this is the normal condition of the stomach. In diaphragm, you will get esophageal hiatus. In that esophageal hiatus, you will get lower esophageal sphincter. That sphincter will be in physiological condition. It is involuntary condition. When we are swallowing anything, that time only it will automatically through peristalsis movement, it will involuntarily, it will open, then that food content will go to stomach. Then after it closes. But here in pathological condition, what will happen? If you see this picture, in this picture, that lower esophageal sphincter relaxes. Because of that, that stomach content will comes into distal esophagus part. That time we will get acid reflux. So this type of condition we call gastroesophageal reflux disease. Most commonly we are seeing this disease in older than 40 age peoples. Because of that reflex, that esophageal part will be thin. Anatomically, disruption of gastroesophageal junction will be happen. Then one condition will be there, that condition we call hiatal hernia. If you see this picture, in this picture you can observe here, this is hiatal hernia. Between esophagus and stomach, you will get this type of hernia, means something bulge formation will be happen. So this condition will be happens in GERD. What are the risk factors in GERD? More amount of alcohol consumption, tobacco, obesity, fat-rich diet, pregnancy, and hiatal hernia, and caffeine. This all are comes in risk factors. Now, clinical features. What are the signs and symptoms we can see in gastroesophageal reflux diseases? Heartburn. First point. This is very important. We can see in gastroesophageal reflux disease. Next, regurgitation. Regurgitation means acidic content will comes in mouth. Then dysphagia, difficulty in swallowing. Then odinophagia, means when swallowing pain will come. Next, cough, laryngitis, wheezing, and damage of enamel of teeth we can see, because that acidic content is coming to mouth, right? Then that enamel strength will be reduced. So in GERD, what are the complications we can see? In GERD, esophageal strictures, then after Barrett esophagus we will study later, then after adenocarcinoma will become. So for treatment purpose, we have to suggest diet modification, histamine blockers. Histamine blockers means that drugs will block parietal cells for producing hydrochloric acid. What are the drugs will come in histamine blockers? Like cimetidine, ranitidine, nizantidine, famotidine will come in histamine blockers, and proton pump inhibitors. The proton pump inhibitors will inhibit the proton pump like hydrogen and potassium pump. What are the drugs will come in that proton pump? Omeprazole, pantoprazole, ebiprozole, lansoprazole will come in proton pump inhibitors. For surgery we can refer Nissen fundoplication. If you see this picture, in this picture that stomach part, fundus part will be stretched and it folds like this, and that doctor will stitches here. So this is this type of surgery we call Nissen fundoplication. Next, Barrett esophagus. In this disease, if person have long standing reflux disease, then that person will cause Barrett esophagus. In Barrett esophagus, what will happen? Metaplasia will be happen. Metaplasia means when that acidic content will damaging that esophagus part, then that esophagus part will be have necrosis. Because of that necrosis, there will be happen metaplasia. Metaplasia means the cells replacing. If you see this picture, as I told you before in previous video, the esophagus is made up of non-keratinized squamous stratified epithelium. Actually here that non-stratified squamous epithelium converted into intestinal columnar epithelium, right? In that columnar epithelium you will get goblet cells. That goblet cells will produce mucus. So in Barrett esophagus, metaplasia will be occur in esophagus area, in distal place, right? Where that acidic content will coming, that place will be forms metaplasia. Most common in this disease, most commonly present in white males, and it's typically present between 40 to 60 years old peoples. This Barrett esophagus may progress of dysplasia and adenocarcinoma, right? If you see this picture, this is the normal cells, squamous epithelium, and this is the changes into depleted cells. This is columnar epithelium. In columnar epithelium, you will get more amount of goblet cells, right? If you see this picture, this is the endoscopic structure. In this endoscopic, you can see white patches and red patches. This white patches is the esophageal cells. This red patches, that is we call intestinal cells, that means columnar cells, right? This is the Barrett esophagus. So next we are talking about eosinophilic esophagitis. In eosinophilic esophagitis, it is the like, if you are seeing eosinophils, that means that is the allergic condition. Some allergic is happening there. If patient like asthma or allergic conditions, this type of people we can say eosinophilic esophagitis. In this condition, what will happen? Infiltration of eosinophils in the esophagus, often into the atopic patients. For example, one child have a peanuts allergy. I don't know about that. So that time I gave one chocolate. So in that chocolate, that peanuts, everything mixed. If I gave that guy and that guy ate the chocolate, then he have a conversation, then he have a allergic reaction, then I admitted in a hospital. In that hospital, the doctor told take endoscopy. In that endoscopy, you will get this type of picture. If you see this picture, you will get ring linear type of structure you can see. If you take biopsy about that cells, you will get this type of eosinophilic cells you will get. It is the, in eosinophilic esophagitis, it is typically unresponsive for GERD treatment. It will not respond, right? This is the eosinophilic esophagitis. Next, we are talking about esophagitis. Esophagitis means inflammation in esophagus. Because of gastric reflux, this infection will be occur. This type of disease will come in immunocompromised patients. For example, some transplants like kidney transplant or AIDS or HIV patients, in their body they don't have immunity power. So many infections, bacteria will come in that body. What are the bacteria will affect? First one, Candida. If Candida will affect that esophagitis, you will get white pseudomembrane. If you see this picture, here you can see white membrane. So this is Candida. Next, herpes simplex virus. In herpes simplex virus, you can see punched out ulcers. Punched out ulcers means that ulcers will form in mouth area. Like you can see in side of your lips, your mouth, and inside of the lips, you can see this type of ulcers. Next, cytomegalovirus. That cytomegalovirus will form linear ulcers. Caustic injections or pills are like bisphosphonates, for example, or tetracyclines, non-steroidal anti-inflammatory drugs, iron and potassium chloride. These drugs will damage mucosal layer. That's why here prone to forms inflammation. In esophagitis, we can observe odynophagia. Odynophagia means at swallowing time they will feel pain, and they have pain in retrosternal place, means here. In this place, that patient will feel pain, right? Next, reflex esophagitis. In reflex esophagitis, because of that reflex, that esophagus will cause like esophagus will burns. Because of that burns erosions, you can see like this. When he's swallowing, he will have pain and dysphagia and like some irritation, and when swallowing he will feel that retrosternal angle he feels pain. So this is the esophagitis. Next we are seeing distal esophageal spasm. In distal esophageal spasm, it is uncoordinated with contractions. Because of uncoordinated contractions, we can't see peristalsis movement. Because of that, esophagus will contract very much. If you see this patient, he will come to hospital like he have a dysphagia and angina like pain. Angina like means like heart attack type. He will feel pain, right? For imaging, if you give barium for swallow, that patient esophagus, we can see like this, like corkscrew. This, if you seeing this image like corkscrew type, we can see here. And another, for permanent diagnosis, for complete diagnosis, we can do manometry. Manometry means one catheter they insert through nasal cavity. From nasal cavity to they will insert to your esophagus. In that catheter, they have some sensitive parts. In that, when that catheter will passing to the distal esophagus, in that esophagus, that sensitive parts will observe how much that lower esophageal sphincter will closing, how much pressure that lower esophageal sphincter will passing movements, we can see in that manometry. Next, for treatment, we can give nitrates for vasodilation, and we can give calcium channel blockers. Because of more amount of calcium, that action potential is increasing, that action potential tone will increasing. That's why that esophageal contracts. That's why we can block calcium channel blockers. So that's why we can block calcium channels. So this is the distal esophageal spasm. Next we are going to see esophageal cancer. Esophageal cancer. Esophageal cancer is divided into two parts, like small cell carcinoma and adenocarcinoma. Small cell carcinoma. If you see small cell carcinoma, it is most common in worldwide. This cancer caused in upper and middle part of the esophagus. What are the risk factors we can see in this small cell carcinoma? More amount of alcohol and tobacco, drinking very hot tea, achalasia, esophageal web, for example Plummer-Vinson syndrome. In Plummer-Vinson syndrome, we studied before, we can see three types of signs and symptoms like dysphagia, iron deficiency and esophageal web. And esophageal injury. This esophageal injury will forms example like ingestion. This small cell carcinoma affects because of nutritional deficiency and eating of polycyclic hydrocarbons, nitrosamines foods. In that food they will add nitric oxide and other mutagenic compounds such as those found in fungus contaminated foods. Fungus contaminated foods means, for example, vegetable pickles, like normal pickles will comes in this fungus contaminated foods and must also considered in small cell carcinoma. If you see this image, this is the upper middle part of esophagus. In that part here, that small cell carcinoma formed and it's blocking that esophagus part. If I see the biopsy test, you can observe this type of histological structure. In this histological structure, you can see keratin nests are pale within the tissue or organ. Next, if you see the outer structure of esophagus, you will get this type of structure in small cell carcinoma. Next, we are going to see the adenocarcinoma. Adenocarcinoma of esophageal cancer. In adenocarcinoma means it is malignant proliferation of glands. This type of cancer is mostly present in America. Before this adenocarcinoma, we can see pre-existing like Barrett esophagus, chronic GERD, obesity, smoking, achalasia. They will have this adenocarcinoma cancer. Usually it's present in lower 1/3 of the esophagus. That means it's present in distal part. If you see this esophagus, in this esophagus, in outer structure of esophagus, you can see this type of structure, right? In biopsy test, you can see this type of cells. This is the esophageal cancer of adenocarcinoma. So today we discussed about GERD, Barrett esophagus, eosinophilic esophagitis, distal esophageal spasm and esophageal cancers. If you like this video, subscribe my channel. If you have any doubts, let me know in comment section. If you want notes, I will say Telegram link in description. Please join the channel. You will get that notes. Thank you.